Good afternoon. Good afternoon. How's everybody doing? Great. Okay, great. All right, so let's get myself situated up here. I'm very happy to be here with all of you. And I know you're all eating, so definitely continue to enjoy. Let me just find a little clicker here. Okay. So I'm going to talk with you a little bit about some of what we're working on in Washington. This is kind of in the backdrop of all of the drama that's going on in a lot of different directions, so we're going to talk a little bit about that. And really the emphasis of my talk is that advocacy right now is more needed than ever. And that's at the state level, the local level, and at the federal level. I'm from Legal Action Center. We are a nonprofit law and policy organization, and we advocate for people with addiction histories, criminal records, and HIV and AIDS. I run our DC office, where we do work with Congress and with the Obama administration to try to increase access to care across the board for the people we serve, and also to eliminate discriminatory barriers that all of our constituencies face. So again, and I just want to thank Madsy for having me here. Thanks so much to Lynn and to Tracy. Madsy is a part of SAS, which is the State Associations of Addiction Services, which is a group we do a lot of work with to ensure that, again, you all have a voice in Washington. So we'll talk a little bit about the biggest things we're working on related to the federal healthcare law, and also some federal funding updates, and again, all with the clear message about what we all should be kind of doing right now to advocate for our people. So we all know that this is a time, and I don't have to tell all of you this, a time of tremendous change and uncertainty, and I think we're all feeling that. I think that's a part of every fiber of everything we're doing right now. But we also feel it's a time of tremendous opportunity and tremendous promise. We know now, again, through the past number of years, with passage of federal parity legislation and passage of a federal healthcare law with strong provisions for addiction and mental health services, that there really is a greater understanding that we're talking about treatable, preventable, chronic diseases. And there's greater understanding that we need to be a part of all of these discussions, and that we have a right to be a part of all of these discussions. There's also greater recognition of our history, that there has been discrimination in coverage in private insurance, and we do have now a fully enforceable federal parity law that we are all working to ensure is being complied with. So there's a lot of work obviously going on in all of your states. We also are pleased that the federal healthcare law did include recognition of the importance of the full continuum of substance use disorder and mental health care. And again, we're really working toward a huge expansion and the ability for many, many more people who need care to get the level of care that they need. However, the elephant in the room, we are at a time when we all have all of these questions up here. We don't know what's going to happen tomorrow. Again, specific to the US Supreme Court, we don't know when exactly they're going to come out with their ruling. We don't know what they're going to say. We don't know how it's going to have an impact on the work that we're all doing to, again, ensure that people are better covered for care and people have better access to care. We don't know how this is all going to work. We also, I know there's a lot of concern about decisions that Congress is making now on federal funding, and we don't know how, again, that's going to affect all of the people that you all serve and all of the programs you all work in. So we definitely recognize that. We also know we have a federal election coming up where we're anticipating some significant change and some new staffers we'll be working with, new members, and again, this is at the state level and at the federal level. So the big question that we always get, and that we always continue to struggle with all of this activity and all of these very important things, what should we be doing right now in terms of advocating, in terms of educating stakeholders and policymakers about the need to increase access to care for addiction and mental health services, and again, to eliminate those discriminatory barriers. So what we do know, these are the things we do know. We know that our current system of care is broken. And we know that there is broad acceptance of that and understanding of that. We know that reforms have been going on and different policy changes have been worked on around the country, and that was before the federal healthcare law. And we anticipate that moving forward regardless of what the Supreme Court says. In particular, ways, again, to get more people covered, ways to improve access to care, integrated care projects. We know that accountable care organizations, health home initiatives, those were moving before the federal healthcare law happened. And again, we anticipate continued support for that work moving forward. We also know that the federal parity law, while the federal healthcare law builds on parity and incorporates a number of very important pieces of parity, we know that the federal parity law is distinct from the healthcare law. And it's not being challenged in court the way the federal healthcare law is. And we know, again, that we have a statute and we have regulations that are fully enforceable by the law right now. So we continue to move forward. We also know that as all of these different reforms are being discussed, that our community has been engaged at every level and participating at every level to ensure that these policies are developed in a way that helps people with addiction and mental health service needs. So that's definitely a good thing, again, that we anticipate moving forward will continue to be the story. And again, what we're all feeling, I think, is that huge decisions are being made that are critically important to the people we are all trying to serve and working to serve, and that advocacy and education and engagement needs to continue to be a huge part of what we all collectively do. So what are we working on right now specific to the healthcare law? So again, there's a lot of uncertainty, but we're going to push forward. On the Supreme Court decision, we are hoping to have a decision by the end of next month. So we will have some more clarity about, again, how we move forward, not if we move forward. So going back to the federal healthcare law, we'll talk a little bit about what we're focused on right now, which is primarily the development of the essential health benefit around the country. And I'll talk a little bit about that. So there are two major ways in which the federal healthcare law tries to get more people covered. One is to expand public insurance through Medicaid. So again, the federal healthcare law seeks to expand coverage to everyone below 133% of federal poverty. And in many states, for the first time, this is going to include childless adults. For those of us who do criminal justice advocacy, we I think are in particular very excited about this piece, this provision, knowing that we have a lot of people who are single adults, who are coming out of incarceration, who have been disconnected from health care, who haven't been covered well, and that this is a huge way to really ensure that people have better coverage and hopefully better access to care. They're expecting about 16 million people to benefit from this Medicaid expansion. The second big way is through an expansion of private insurance. And as you know, many states around the country, not all of them, but many of them, are doing work to create state-based health insurance exchanges, where individual and small group health plans will be functioning. And what's common to all of these plans, and I'll talk a little bit more about this, is that there's a benefit package that must be offered by all of these plans, and that includes substance use disorder and mental health services. And those services, those benefits, must be provided in the same way as other benefits by that plan. So I'll talk a little bit more about it. But back to the private insurance exchanges, the plans will also need to have a network of providers that is sufficient to both the kinds of providers and the number of providers to provide addiction and mental health care. This is something that you may remember the field was really fighting for as the federal government was coming up with rules about how states should be setting up these health insurance exchanges. There was a lot of concern from the field about making sure that providers of addiction and mental health services are fully included in that, and that there are provisions that, again, enable the field to fully participate. So we were really pleased that the final regs at the federal level, after a huge push by the whole field, did include very specific language about ensuring that mental health and substance use disorder providers are in that system and will be a part of that. So the essential health benefit work, as I mentioned before, this is something that was set up in the Affordable Care Act, in the federal health care law. Congress identified 10 categories of care that have to be provided by all of these different plans, and I'll detail that in a second. But these are the different categories. And you'll notice that, again, there is a specific category on mental health and substance use disorder services. One thing I just want to underscore is that we know that there are important elements and services in many of these other categories for people with substance use disorder and mental health service needs. So we are certainly focused on the mental health and substance use disorder category, but we're also trying to ensure that as we work in coalition with other allied groups, that they are mindful that some of these other categories, again, are extremely important for the people we all serve. So these essential health benefits, which kinds of plans have to adhere to these requirements, and again, have to provide substance use disorder and mental health benefits at parity with the other benefits provided by that plan. The types of plans are, again, those small and individual group plans that, small group and individual plans that are operating in the state-based health insurance exchanges. So those plans, again, must order substance use disorder and mental health benefits at parity. Also, small and individual plans that are operating outside of the health insurance exchanges, which was something we were pushing for very hard. Again, those plans are also required to offer the essential health benefit package. Also, those plans that are being provided to the new Medicaid expansion population for people who, again, are in that new benchmark Medicaid world, they have to also be provided with substance use disorder and mental health benefits at parity. Large group plans and traditional Medicaid plans do not have to adhere to the essential health benefit requirements. So again, wherever the essential health benefit requirement is, wherever there's a requirement for substance use disorder and mental health benefits, there's also a requirement that those benefits be provided at parity with other medical and surgical benefits provided by that plan. So again, just to talk about how that is an improvement on the federal parity law, as you all know, the federal parity law only applies to large group plans, and it only applies to those large group plans that choose to offer mental health or addiction services. Here, there's a requirement for small and individual plans to offer addiction and mental health benefits, and those benefits must be provided at parity. So that's something that we're again very excited about. It's a real change and a real shift. And again, the essential health benefit is expected to apply to about 70 million people, which we're again excited about. As you also know, even though the federal healthcare law is over 2,000 pages, they did not define any of these benefit categories. They did not define what a continuum of care looks like for any of those 10 benefit categories. It's not just addiction and mental health category, it's all of the categories. So we are all working and have been working since passage of the law, knowing that it's wonderful that we got some good coverage in the statute, but that if implementation is not done well, it's all pretty much for naught. And if we aren't able to get a really robust essential health benefit with really strong addiction and mental health service coverage, then again, it's going to not help people the way we really want this to help people. So Congress's intent was for the federal government to define what these services would include. But as you all probably know, in December, the federal government came out, the Department of Health and Human Services, came out with a kind of framework, the way that they are looking at the essential health benefit work moving forward. Instead of the federal government defining this, they wanted to leave it to each of the states to do work in their own state, to look at the plans that are offered in your state, to benchmark to one of the plans that's been operating in your state. So again, that's a very strong state role, less emphasis and less direction from the federal government. So we are seeing that that is kind of cutting both ways. I think in some ways it empowers state advocates to really get in there and be able to work with those policymakers and decision makers you've been working with for a number of years to be able to ensure that the benefit package in your state is again strong on addiction and mental health coverage. But we know also that it's an area of concern in a lot of places, that I think some states would have really liked more prescriptive guidance from the federal government. So it's what we have right now, and we are doing what we can to ensure that advocates around the country have as much information and as many tools as they need to really try to ensure that these benefit packages are strong in terms of addiction and mental health services. So, the way that the federal government set it up, there are 10 different plans that states can choose to benchmark to. And so these are the 3 largest plans in the small group market that operate in their state, the 3 largest federal employee health benefit plans operating in their state, or the 3 largest state employee benefit plans, or the largest HMO. So for states that do not choose, the default plan is the largest small group plan. And states are supposed to be doing this work with a deadline of September. As we all know, unclear. What have we really been hearing? I'll get into that in a moment, because we do work with a lot of advocates around the country, and as you might imagine, the experience of this work is very different in kind of all across the board in terms of how quickly the activity is going, but we'll talk about that in a minute. So again, states have a lot of flexibility to define their essential health benefit. What we found is, again, that the statute has required that the plan coverage should look like typical employer coverage. And again, I think in our field, with our history, Congress recognized in a clear, uncontroverted way that our history of private insurance coverage for addiction and mental health benefits has been unacceptable, which is why they passed the parity law. So it's a little bit of a challenge under kind of that construct that we're supposed to look at what has been typical, knowing that what has been typical has not been acceptable. So we are looking at a couple things, and I'll mention that in a moment, but we did some work. I should have mentioned that Legal Action Center, my organization, we co-chair a coalition called the Coalition for Whole Health, which is a group of national organizations in the mental health and addiction communities. We've been working together for, goodness, like, I guess 4 years now. We started working together as health reform started, feeling that it would be very important for us to be as cohesive as possible and to develop consensus positions and to speak with one voice as we advocate with Congress and with the Obama administration. So our coalition retained Milliman to do an actuarial study to look at the mental health and addiction services that are covered through private insurance to see what has been typical. And we were pleased that in some ways it covered a more robust group of services than we had kind of anticipated. One of the areas where we've heard from the field, particularly the addiction treatment field, has been concern about residential addiction treatment and whether residential addiction treatment services will become a part of the benefit package. We were pleased to see through this analysis that most plans have included some coverage for residential addiction treatment. A small caveat to that, as you all know, it's unlikely that most plans have been providing the adequate amount of the service, which is a different discussion. And again, we've been working very hard to ensure that the essential health benefit package includes as robust a group of services as possible. But we fully acknowledge that we're going to continue to have a fight to ensure that people get the clinically appropriate amount of care. So just a caveat on that. I'm going to take a quick sip of water. Okay. So, a couple of other things that were built into the statute and that have been echoed in subsequent guidance by the federal government. The essential health benefit packages that are developed by states have to be consistent, again, with parity requirements and with additional non-discrimination language that's in the federal healthcare statute. And again, this, I just want to underscore, is extremely important. Because as states have started to look at the benchmark plan options, we want to underscore that as the state picks that plan, parity has to be complied with. So if a plan is selected that has very weak mental health and addiction coverage, the plan would have to supplement and put in additional services to, again, comply with parity. So I think there's been concern that advocates have kind of a limited ability to influence the work moving forward in their states, and that it's a kind of a finite universe of plans that are being selected. Parity, again, it's a legal requirement that these plans have adequate addiction and mental health coverage. We also have good language in some of the guidance that is intended to protect against substitution for other types of services again. There also is some discussion in the guidance about the actuarial value of the mental health and substance use disorder benefits and protections, so that if services have to be added, benefits have to be added, that it doesn't hurt the actual actuarial value of the entire package. This is not something that could hurt kind of the overall value of the plan, of the benefit package. So there are some protections that are there that we think should, again, help to ensure that there is good coverage. And again, we feel that state advocates, this is what you all do. The people you've been working with for many years are many of the decision makers who are totally involved in this process, and so we can talk a little bit about some tools that we have. So first, as I mentioned, the Coalition for Whole Health has done some work to look at the services that we think should be a part of the essential health benefit package. So we developed a paper, and we have over 100 national and state groups that have signed on. We are really pleased too that it's been used as a tool to help evaluate some of these benchmark plan options. SAMHSA, the Substance Abuse and Mental Health Services Administration, did a training a number of months ago with the state mental health and substance use disorder directors, and they actually used the recommendations of the coalition in their trainings and their webinars for the state directors and their staff members to compare the various plans in each state with the recommendations of the coalition. So we hope it's a helpful tool moving forward. That was definitely our intent. Some of the principles that the coalition emphasized in this paper, again, to really emphasize that as we look at the types of services that people need, we need to remember over and over that we are talking about chronic illnesses, and that we need to have services that are available for long-term recovery, just as with other chronic diseases. We also were we wanted to emphasize the need to have the full continuum of care represented. And finally, there was a lot of discussion about ensuring that any medications that have been approved for the treatment of a mental illness or treatment of substance use disorder should be included. So these are the services, a number of the services that, again, the coalition recommended be covered, and it includes, again, the full range from outpatient, intensive outpatient, inpatient hospital services, residential addiction treatment services at the ASAM level of care of 3.0. Prescription drugs, again, for the treatment of mental illness and substance use disorders, services for kids. Also prevention and wellness services, again, analogous to some of the other services that are offered to avoid other types of chronic disease and to promote wellness. And again, other types of chronic disease management and recovery coaching types of services. Something that we've been really looking at is how other diseases identify and call some of these services that we have been offering in our field to help people stay well and to help manage their disease for a long time, and to really ensure that we are being very specific about what we're talking about to make the argument that these are necessary supports that should be covered. So again, with the essential health benefit work, as we've been hearing from advocates around the country, what have we been hearing? It's, again, very different in a number of different places. Some states, like California, have been moving forward very quickly. The state retained a firm to do the analysis of the 10 different plans, and advocates in the addiction and mental health communities are working together really closely to, again, ensure that the benefit package includes adequate, as good as possible coverage for addiction and mental health benefits. It's been very interesting in some states that haven't been moving forward with Affordable Care Act implementation. We were kind of unsure about what the state would be doing in terms of analyzing the various plan options and picking the essential health benefit. One example that we heard, which we were encouraged by, is that in Mississippi, apparently, even though they're not moving forward with exchange activity, they have been doing a very robust process to look at the essential health benefit, and addiction and mental health advocates have been very much a part of that and engaged in that process. So that's been something very encouraging. Some overarching kind of concerns that we've heard from advocates around the country. Again, I think it's focused on certain types of care and certain modalities that we have seen being excluded in many private insurance plans. And again, there's been concerns specifically about residential addiction treatment. And we have heard in a number of cases, lots of exclusions for methadone. So those are two pieces where, again, we've seen some concern. Also we have heard about, again, prevention services, wanting them to include addiction and mental health screenings. It's something where I think at the federal level, we've seen a lot of support for SBIRT, for screening, brief intervention, referral to treatment, but in private insurance plans, they haven't typically covered these services as well. So that's another place where we think that advocates are going to have to work hard, but that it's possible to ensure that these are additional services that are covered. And then finally, as I mentioned earlier, having other types of services that are covered for other chronic diseases to help people not just to get well, but to stay well. I think advocates, again, have had an eye on certain recovery support services and how they can advocate to get those in. So again, what should we all be doing on this right now? I think what we've been recommending to advocates, and again, I should say that there are advocates that are moving forward way faster than we are at the federal level and are doing really, really good work. And that, again, there's a huge variation of activity. But what we've been encouraging people is to really find out what activity is going on in your state. Who the people are who are reviewing those plans, where the decision makers are. One way to kind of break into that is to really try to connect with your state mental health and addiction directors. Again, they were charged with a process of trying to start to do this analysis. So it would be good to kind of check in and see how that analysis is going. And then again, with the goal that we all want is for advocates to have this information, to have the information about what kinds of addiction and mental health services are provided in these plans, so that we can fight to ensure that the plan that's adopted has strong addiction and mental health coverage. We, again, have been encouraging advocates to remember that the federal parity law does provide some protection for us here, and not just accept if a plan appears to be about to be accepted and selected by the state and appears to have some weak coverage, that it has to meet parity requirements and has to have care that's comparable to other types of medical surgical benefits provided by that plan. If you have questions about that as you do the work, we are working hard to try to get good resources out there and to try to have people who do this work kind of day in, day out to help do some of that analysis. Identifying the levers, really looking again, who are the decision makers, who are the ones who are central to this work, and how can you work with them. Again, it's different in different states. Some of that work is situated in different places in government. Some states there's a focus by the governor's office, and other states it's through the legislature that they're doing a lot of work. So really just trying to figure out the lay of the land, and again, then figuring out where you have leverage to help influence that process. If we could mention just a few important people, and again, I think we've been all talking about this, and we all recognize that there are a number of decision makers who some advocates haven't worked as closely with as other communities. The first being our insurance commissioners in each of the states. They have huge importance in relation to parity, the federal parity law. For most of those plans that have to adhere to parity, the state insurance commissioner is really the first line of defense. They have primary jurisdiction over ensuring that the law is being complied with. They also will have huge work to do as these health insurance exchanges are being set up and the various plans are operating within those exchanges. So I think as a community, we know that advocates are really either strengthening those existing relationships with the insurance commissioners or really forging new relationships. And I think it's important to remember that we as a field have a lot to offer here. I think that, again, because private insurance coverage has been so weak for addiction and mental health services, that there's huge value in helping to educate staff in these insurance departments about your work, about services, about addiction and recovery. We've found that in certain states, we have some advocates in Texas who aren't able to do any kind of work in a loud way on the federal healthcare law, but when they approached their insurance commissioner on the federal parity law, which again is a distinct law that was supported by a bipartisan Congress and signed into law by a Republican president, that's been a helpful thing to remind people about. They were welcomed, and they're having some good discussions there to help to educate them about how parity needs to be complied with. So there are a lot of different ways to do it. So another person who we all know is extremely important as all of this work moves forward is your Medicaid director in your state. Again, we know that the Supreme Court review is creating a lot of uncertainty, but I think a lot of people feel confident that out of all of the pieces that are being challenged, that the Medicaid expansion has the most likelihood of staying, of remaining federal law, and that we anticipate the Medicaid expansion to happen. So I think, again, as a means of expanding care, looking at our field and where the expansions may take place, strengthening those relationships with your Medicaid directors and the staffers there, I think is extremely important. And then the last person I'll identify, the Federal Department of Health and Human Services have regional offices around the country. And often what they hear will bubble up through the Federal Department of Health and Human Services, and that seems to really elevate matters at the federal level. And even though we have good state activity, and that's the framework we're working in, it's always helpful for our friends at the federal level to be hearing about how things are going on the ground and where there need to be different forms of guidance and different pieces coming out of the federal government that will help us ensure that the laws are being complied with. That's something very important. So if you haven't been working as a community with your regional HHS person, we definitely encourage you to reach out and make friends, make some new friends. Also, we definitely encourage you, again, I think it's at a time when so much of the activities at the state level, that any opportunities to be able to share information and to learn from some of your colleagues, I think are helpful. SAMHSA has just recently created a learning collaborative for a number of states to try again to educate about the healthcare law, and in particular about the essential health benefit process. Maryland is one of the states that is going to be a part of that, and we're going to be doing some work with advocates in Maryland, so we're very excited about that, to again help with some of the tools to help educate your decision makers about this work moving forward. The Coalition for Whole Health also has a state implementation working group, and we're setting up a schedule of both kind of calls on a number of issues related to setting up insurance exchanges and Medicaid expansions and enrollment policies, where we'll both have national experts, content experts talking about these things, but we're going to do a follow-up call a week later for state and local advocates to brainstorm and to strategize. And we're really trying to create those places where people can share experiences and talk about how successes happened and how people have been able to overcome different challenges. So that's the Affordable Care Act work. I'm gonna look at my time and then we'll fly through some of the rest of this. Just wanted to talk a little bit about some of the continued work to ensure that there's strong funding for the field. And again, it's been something we've been very cognizant of. We were a little worried after passage of parity and passage of the federal healthcare law with some good provisions for addiction and mental health, that Congress would kind of sit back and think, okay, people have what they need, people have better coverage, and we're okay. So we've been working as a community to ensure that they remember that at this point, coverage has not been expanded at all. And we continue to need various safety net programs, including the Substance Abuse Prevention and Treatment Block Grant, to ensure that there's strong support for services around the country. So that's kind of in this interim period. We also have been encouraging them to look at the experiences of states that have gone toward universal coverage and about how the people who remain uncovered are disproportionately people with untreated addiction and mental health needs. So we have really the argument to ensure that these safety net programs that haven't really been operating as a safety net, they've been operating as the funding source in many of our programs, that we will continue to need these dollars to support people who remain uncovered, people who slip through the cracks, but also services that are not included in the essential health benefit packages. Of course, we're all working very hard to make those packages as robust as possible, but we recognize that not every service that people need is going to be included in every benefit package around the country. So these programs are going to need to continue to support those critically important programs. So just very quickly where we are right now, and we're very excited for those MADC members. We are going to do a Hill Day with all of you on June 6th, and we'll be preparing some good materials and doing some briefings. And just want to underscore for those of you who were able to come here today, again, it's your work with not just your state level people, but your federal delegation is just increasingly important. We're at a time where I think we're all facing a lot of budget cuts across the board, and we're working very hard to ensure that we can be protected. But it's a very difficult thing, as you all know. It's something we're very concerned about. We don't know how things are going to move forward. We don't know where we're going to have opportunities for them to make choices about different types of health and social service programs that are protected. So we all need to speak with a very strong voice to ensure that they understand that the federal investment in prevention, treatment, and recovery services is critically important. So I'll just say very quickly about the proposal that came out in February, the President's budget proposal for 2013, this upcoming fiscal year. We've seen over the past couple of years some pretty significant changes that are proposed in the budget. And one that we focused on is a proposed change to the Substance Abuse Prevention and Treatment Block Grant. And this would remove the required, and this is a requirement by the statute, by the federal law, that 20% of dollars in the Substance Abuse Prevention and Treatment Block Grant that come into states have to go toward prevention activities. There's a proposal at SAMHSA to remove that money and to start a new grant program. And it's something that the field took very seriously when this proposal came out last year. And we don't like to disagree as a community with SAMHSA, but we had some real concerns, and we were very clear in expressing them. We feel that it's a time when Congress is making a lot of decisions about cuts and not a lot of decisions about creating new programs. And we didn't ever want to put a program at risk, knowing that, again, this is really the Substance Abuse Prevention and Treatment Block Grant is the foundation of our system. So we, again, expressed that with our members of Congress on behalf of all of our memberships. We were all on the same page about that, and Congress heard us. Not only did they maintain the current structure of the block grant, but they also, in the House, the Republican House Appropriations Committee approved an increase to the block grant. So for those of you who are very worried that the program doesn't have strong support in Congress, I think the field was really pleased to see such a strong show of support. This proposal to split apart the block grant is in this budget again this year, so again we're doing a lot of work to ensure that Congress hears that this program needs to remain whole and that we need really strong federal funding to support all the work that you're all doing. We know that states are facing a lot of budget cuts and that there's, again, a lot of uncertainty about how the federal healthcare law is moving forward and various state laws are moving forward. And we, again, feel that it's a bipartisan issue. We've gotten good support in the Senate and the House. It's something that we are encouraged by, but again, we need to keep up the push to work together on this. So we, again, are working really hard to ensure that there's strong funding across the board for prevention, treatment, and recovery services. Again, I wish I could tell you that I knew what would happen this year in particular. We know that the deficit reduction legislation is going to result in mandatory cuts to discretionary programming unless Congress acts. We don't know if Congress will act. We have a better idea about when Congress will act. It's likely that they're going to put off a lot of this until a lame duck session, which will happen after the election. But again, we're all just going to continue working kind of on the micro level to make sure that SAMHSA programs are as strongly supported as possible. And then we're also joining with our colleagues in some of our allied health communities to really push to ensure that these cuts can't go forward. They will really harm people in a very fundamental way. So again, what can we all continue to do? Education about all of the great work that you all do, that people do recover, that we need to really continue to emphasize that there are wonderful things that this community does, and we need to keep pushing forward on that. Connecting our work in DC, this is incumbent on us to make sure that we're getting good information out to all of you, and that we are really informed by all of the work that you all do, that we want to make sure that we're saying the right things and pushing for the right things with people in Washington, so that back and forth is extremely important, I think, again, now more than ever. Speaking with a cohesive voice. Through our coalition work, we recognize that we don't agree on every single issue, but we agree on a ton. And there are many, many things that we can focus on and we can work in a consensus-based way, so our message is that much stronger and that much clearer. We also are constantly trying to not just work with our kind of existing champions, which I think it's a growing group, but we would like more and more champions at the state, local, and federal levels, but really looking at how to cultivate new champions. Again, I think we're all anticipating, we know there are going to be some new members of Congress and new staffers to work with. We'll be doing some analysis to look at the backgrounds and to look at the experiences and to hear from all of you, for those who have come from the state world, who are coming to the federal system, who we can really cultivate as supporters and figure out how to ask them to help us. I think that's something that we continue to struggle with and continue to be very targeted in terms of what we ask for. Protecting the safety net, again, this is hugely important now and moving forward for years to come. Monitoring implementation, again, this is something that we rely on all of you and all of your colleagues around the country to really let us know how things are going. If you're seeing problems with specific health insurers that don't appear to be complying with the parity law, that there's a way for you to connect to some of us at the national level who can then elevate that and share that with some of the people we work with. The same goes for the health insurance, for all of the health insurance expansions and the expansions through the Affordable Care Act. And then finally, one thing I also would like to mention is that we're very excited, of course, about the healthcare law to expand access to care, but we're very mindful that another piece of this is the huge host of legal and policy barriers that people continue to face, many in recovery, many who have criminal histories, And there's huge continued work that needs to be done there to make sure that people can fully be a part of their communities and be in a good place. So we are going to continue on with that, and I'll just leave it there. But any questions? Thank you so much. Questions? Comments? Yes.
I applaud you for the good work that you guys do. I think it's really, really essential, especially because we don't have a very strong lobby. But I'm looking at residential programs, and I'm looking at the totally local level, that the residential programs are slowly getting squeezed out by Medicaid and by private insurance, reducing the number of days, and then we have become enablers because we do not want to put the people out. We start taking the outpatient level of reimbursement. And they turn around and they say, hey, look, with outpatient, these people get better. And it is not true at all. But I'm here in this state for 8 years, and I haven't seen any new residential programs. I've seen residential programs close. So the writing is on the wall, I see, that we're getting slowly squeezed out. Your comment?
Sure. And so the question was about really the future of residential addiction treatment care and what we see coming. I think, again, it's a very different question to talk about ensuring that residential would be a part of a benefit package moving forward. I think that's kind of definitely the easier lift as compared with making sure that it's managed well. I think it's definitely a level of care that we have heard. We've done some work in this area with some advocates and with some insurers who have recognized the need for that as a level of care, but there has been concern about lengths of stay, as you know, and concern about how we talk about residential. This is something that has come up time and again as we've worked with additional policymakers kind of outside of our traditional world, even those in the healthcare world who, when we say residential addiction treatment services, they don't know what that includes. They don't know what that means. They don't know what that looks like. So I think we as a field have to do a better job of really defining that and of ensuring that they understand that these are medical services that people receive, and again, continuing support services that people receive for other types of chronic diseases. It's something where we understand that there are going to be continued challenges moving forward. We also have seen this a lot, as you were saying, that then people move into kind of a level of care that isn't always appropriate for them. And we have seen lots of resistance, I think, from other communities about using housing dollars, I think, to support people, and other kinds of models that there is evidence for. So I think it's definitely a piece of the continuum that will remain a piece of the continuum, but I think it's a matter of a lot of work that needs to move forward. It's a challenge. I don't know if others, I see maybe here who's nodding and saying things. You wanna? No? Okay.
I wanted to say something about that. I couldn't stand it. Any of you remember what happened in mental health about 25 years ago? I'm great for history because I've been around a long time. When mental health decided it wanted to build Medicaid for services in psychiatric halfway houses and had to unbundle, quote unquote, unbundle the cost of the residential component of a psychiatric halfway house and the clinical services that were being provided. Yeah, well, I was running a division of a psych hospital at the time that had halfway houses. And I want to tell you, creative billing is wonderful. Residential providers want to survive. This business of I get paid a daily rate, gone. I mean, there's no point in belaboring the issue. You have to unbundle the cost of what you're providing in the residential setting unbundle it from the housing cost, the building that you're in. Think about other sources of financing for the housing piece. In the old days, we can't do this with substance use right now, but we might again. When I was doing it in mental health, SSI paid for the housing costs and Medicaid paid for the clinical costs. Now, we can't do that for substance use disorders right now because we're not a disability. But people are going to have to get creative if we want to. We're not a disability by legal definition. Not because we're not a disability. People are going to have to get creative about this if we want to preserve residential services for some of our patients. We can't be sitting here saying, do it for us. It's not going to happen.
I'm going to turn the microphone, thank you, Mady, and thank you for the question, over to Lynn. I'm going to stay for a little while if there are any other questions. And again, just really thank you for all of your work and for having me here today. Thanks.
Thank you so much, Gab.